Welcome to the Health Headliner podcast by Tudu Digital. Our content is informational only and not medical advice. Please consult your provider. Now, let's dive into today's headlines.
Welcome to the Deep Dive. Today we're tackling a topic that, for so long has just been about setbacks and, frankly, a lot of heartbreak. That's the search for a real treatment for Alzheimer's disease.
It really has been a tough road.
But our sources today, they're pointing to something pretty revolutionary. For the very first time, we actually have drugs, Lecanemab and Donanemab, that seem to show a clear, replicable signal that they can genuinely slow down how this disease progresses.
That's right. Scientifically, it feels like a real turning point. We're shifting, from just managing symptoms to potentially modifying the actual biology of Alzheimer's.
Okay, but here's the puzzle, the paradox we really want to get into today. Despite this sounding like a massive win, maybe one of the biggest breakthroughs we've seen, these drugs are facing intense skepticism.
Yeah.
It really runs the gamut from excitement to really strong opposition.
It does, and that's what makes this whole thing so complex. Why the division? It boils down to, a few key things. How much benefit patients really get versus the huge cost, the sheer difficulty of administering the treatment, and the safety risks involved.
So our mission today is to try and cut through some of that noise for you. We'll break down the results for these anti-amyloid antibody drugs, put the risks into context. How do they stack up against treatments for other serious diseases?
And crucially, we need to talk about a parallel revolution happening in diagnostics, especially blood tests, because that's changing the whole landscape too.
All right, let's start with the science bit. These drugs target something specific in the brain, right? The core pathology of Alzheimer's. Can you explain that simply?
Sure. So Alzheimer's involves this buildup of sticky proteins called beta amyloid in the brain. They form these clumps or plaques. These new drugs are basically engineered antibodies, kind of like specialized proteins from our immune system. Their job is to target and help clear away that amyloid pathology. Think of them like a cleanup crew. They latch onto these amyloid clumps and signal for them to be removed. They don't cure it, but they actively reduce what we think is a root cause.
And the big clinical trials, the phase 3 ones, what did they actually find when they tested these drugs on people?
Well, the results were pretty consistent across the board. They showed a slowing of decline. So Lecanemab, over 18 months, slowed down the progression of cognitive and functional decline by about 27%, based on a standard scale they used.
27%.
And Donanemab showed an even bigger effect, around 36% slowing over that same 18-month period. It essentially proved the concept. If you clear the amyloid, the disease progression does slow down.
Those percentages sound impressive, but what does that actually mean for someone living with the disease or their family? Can you translate that into real-world impact?
Yeah, that's the key question, and this is the number you should probably hold on to. On average, it works out to about 6 months of delayed progression over that 18-month study period compared to those who got the placebo.
6 months delay over 18 months.
Exactly. Now, it's crucial to understand patients still decline. The disease isn't stopped. But on average, they maintain their abilities, their independence, for about half a year longer. That could be the difference, say, between staying in the mild stage versus moving into moderate dementia during that time.
So that 6-month delay, that's the trade-off we're really talking about here. It's not a cure, it's buying some time. And that's what makes these fundamentally different from the older drugs we used to have.
Precisely. Before this, we only had symptomatic treatments, things like Donepezil. They might give a temporary cognitive boost, maybe equivalent to delaying things by 6 months overall, but in a disease that can last 10 years or more.
Right, the effect gets washed out.
Yeah, and critically, they do absolutely nothing to the underlying amyloid buildup. These new antibodies are different. They actually change the biological trajectory of the disease, and the hope, the expectation, is that this benefit will accumulate, will add up over many years of treatment.
Okay, but this is where the skepticism really starts to bite, isn't it? Because even if the benefit grows over time, the upfront cost and the immediate risks, they're huge. Let's talk money first. What kind of price are we looking at?
Yeah, the sticker shock is definitely real. These are complex biologic drugs to manufacture, and the estimates hover around $25,000 per patient per year.
Wow, per year.
Per year. Now think about how many people have Alzheimer's. If you applied that U.S. level pricing across Europe, for instance, some analyses suggest the annual cost could blow past $133 billion.
Hold on. $133 billion.
That's all it's time.
More than half the entire EU pharmaceutical budget just for these Alzheimer's drugs.
That's the potential scale we're talking about. It forces a really difficult conversation about resource allocation, about what health systems can actually afford.
It's not just cost then, it's potentially crowding out everything else.
It could, yeah. And adding to that pressure is the fact that these treatments aren't suitable for every patient with Alzheimer's. Far from it.
Okay, tell us about that. Who actually gets to potentially benefit from this breakthrough?
Right now, the approval is very specific. Patients need confirmed proof of that beta amyloid pathology in their brain, usually through imaging or spinal fluid tests. And crucially, they have to be in the very early stages, either mild cognitive impairment or mild dementia.
So not for moderate or severe stages.
Not currently, no. And when experts factor in those criteria, plus other health conditions that might exclude someone, the estimates are that only maybe 8 to 15% of all people with early-stage Alzheimer's would actually qualify in a real-world clinic setting.
8 to 15%. That's a much smaller slice than you might initially think.
It is. It's a breakthrough, but for a highly selected group right now.
And beyond the cost and the limited access, actually getting the treatment sounds like a major commitment. This isn't just popping a pill, is it?
Not at all. The treatment burden is significant. Lecanemab needs an intravenous infusion, a drip, every 2 weeks. Donanemab is every 4 weeks.
Every 2 weeks.
Wow. So you could be going from maybe 1 or 2 doctor visits a year to potentially 24, maybe 30, even 35 trips to a clinic or hospital just for the infusions. And that's before you add in the necessary monitoring.
Right, the monitoring, because there's a specific safety issue they need to watch out for, something involving the brain itself.
That's the main one, yes. It's called ARA, which stands for Amyloid-Related Imaging Abnormalities. Basically, as the drug rapidly clears the amyloid, the brain can sometimes react by developing temporary swelling, that's ARIE, for edema, or small microbleeds, tiny hemorrhages, which is ARIAH.
Swelling and bleeding in the brain sounds pretty alarming, even if they're small. Do patients feel this happening?
Most of the time, actually, no. The majority of ARA cases are asymptomatic. The patient doesn't notice anything. That's why the regular monitoring with brain scans is absolutely mandatory. However, sometimes ARA can cause symptoms like headache, confusion, dizziness, and in rare instances, it can be serious. Across the big phase 3 trials for both drugs combined, there were unfortunately 9 deaths that were attributed to the treatment effects, likely related to severe ARI, so the risk, while small, is very real.
And I remember reading that the risk isn't the same for everyone. There's a genetic link.
That's correct. There's a well-known gene called APOE, and carrying a specific version, the epsilon 4 allele, significantly increases the risk of developing ARIA. We're talking 3 to 6 times higher risk for those individuals.
3 to 6 times higher. Okay.
Yeah, which is why genetic testing is often discussed and why everyone undergoing treatment must have MRI scans before they start, and then multiple times during the first year, often 3 or 4 scans specifically to watch for any early signs of ARIA.
Okay, let's just pause and take stock here. We have drugs that slow decline, giving maybe 6 months extra time over 18 months. But they cost around $25,000 a year, need dozens of infusions and scans, only work for a small, select group of early-stage patients, and carry this, albeit small, but potentially fatal brain side effect, especially for those with a specific gene.
That sums up the core dilemma, yes.
So let me play devil's advocate. Why all the breakthrough talk? Is that 6 months of delay truly clinically meaningful enough to justify all this cost, complexity, and risk? Isn't that the crux of the controversy?
That absolutely is the heart of the debate. But, stepping back, many experts in the field argue that the level of scrutiny these Alzheimer's drugs are facing is kind of disproportionate, especially when you compare them to biologics used for other serious chronic diseases.
Okay, interesting point. Can you give us some comparisons? How much risk or cost do we typically accept for treatments in, say, cancer or other areas?
Let's look at cancer, oncology. Immunotherapies like pembrolizumab for advanced lung cancer. Huge breakthroughs, absolutely transformative for some. But if you look at the trial data, serious side effects happen in about 27% of people getting the treatment.
27%. Serious side effects.
Yes. Now, compare that to the Alzheimer's drugs we're discussing. The rate of clinically serious ARA, the really worrying kind, was much, much lower, somewhere between 0.3% and 1.5%.
Okay, so that's a stark difference. We seem to accept a nearly 1 in 4 risk of serious problems for a major cancer drug, but a less than 2% risk for an Alzheimer's drug causes this huge uproar.
That's the comparison some experts are making, yes. And it's not just cancer. Think about other chronic degenerative conditions like multiple sclerosis, MS. Newer MS drugs have been great at reducing relapse rates, maybe by 46% to 59%, which sounds fantastic. But often, their actual impact on slowing the long-term progression of disability in MS has been more modest. Yet, those drugs are widely accepted. The argument is that the magnitude of clinical slowing we're seeing with these anti-amyloid drugs in Alzheimer's is actually quite comparable to those modest but accepted effects in MS. The data looks similar, but the reaction is very different.
So if the science, the effect size, the risk profile, if they're broadly comparable to accepted treatments in other fields, then this intense controversy around the Alzheimer's drugs must be fueled by other things, non-scientific factors.
I think that's a fitty assessment. There are definitely societal factors at play. Firstly, you just can't ignore the history here. Decades of high-profile failures in Alzheimer's drug development have created this deep-seated nihilism, almost a learned helplessness or pessimism about any potential treatment.
We've been burned before attitude.
Exactly. Then, secondly, and this is uncomfortable, but ageism likely plays a role. Alzheimer's predominantly affects older, often vulnerable people. And unfortunately, societal resource allocation decisions, sometimes unconsciously, tend to favor younger populations perceived as more productive.
And the sheer scale of the disease itself must just dominate the conversation about resources.
Absolutely. You mentioned the potential cost earlier. When you have a disease with estimated global costs soaring past $1.3 trillion for all dementias, any expensive new drug immediately triggers massive anxiety about affordability and resource allocation.
1.3 trillion.
And here's a key difference compared to, say, cancer, where medical treatment costs are often the biggest chunk. For dementia, unpaid informal care, usually family members caring for loved ones at home, accounts for something like 54% of the total cost.
Over half the cost isn't even medical bills.
Right. So when a health system looks at paying $25,000 a year for a drug that delays progression by 6 months, they might see it not just as a high drug cost, but as adding a huge new medical expense on top of the already overwhelming long-term care and societal costs.
This is fascinating because it really highlights the tension. But if the treatment side is so complex and debated, the diagnostic side seems to be undergoing this parallel, almost unqualified revolution. And maybe that could help with some of these bottlenecks. Let's shift to these new biomarkers.
Yes, this is arguably just as big a story. We're talking about highly accurate blood tests, specifically one called plasma p-tau217.
p-tau217. And what's amazing here, as I understand it, is that this single blood test seems able to accurately detect both of the key Alzheimer's pathologies we worry about, the amyloid and the tau tangles.
That's the incredible finding, yes. P-tau217 measures a specific form of the tau protein, and its accuracy in reflecting both the amyloid plaque burden and the state of tau tangle pathology in the brain is, frankly, stunning. Our sources suggest these blood tests are performing as well as, or sometimes even better than, the traditional methods.
Better than CSF tests, you mean, the spinal taps?
Yes, better than cerebrospinal fluid tests, which are invasive, or PET scans, which are expensive and not widely available.
This feels like a complete game changer, especially for health systems trying to figure out who might even be eligible for these expensive new drugs.
It absolutely is. Think about the complexity we just discussed, the infusions, the MRI monitoring. That whole pathway only really becomes feasible if you can simplify and streamline how you identify the right patients in the first place. Blood tests are relatively simple. They're scalable. You could potentially do them in a primary care setting. And if they're accurate enough, they could dramatically reduce the need for those more complex, expensive diagnostics, the PET scans, the CSF taps. The estimates suggest maybe by 80 or even 90%.
An 80 to 90% reduction in the need for those complex tests. That's enormous. It could totally reshape how we approach Alzheimer's diagnosis and care planning.
It really could.
So what does having this kind of accurate, scalable diagnostic tool mean for the future? Does it open the door to, well, screening people much earlier?
That's exactly where the thinking is going. It creates the potential for, and certainly raises the massive question of, proactive screening. Historically, we only tested people once they already had symptoms, memory problems. And now, if we can accurately detect the underlying brain pathology using a blood test in people who are cognitively normal, who have no symptoms yet, well, that pushes us firmly into the territory of secondary prevention.
Trying to catch it before it even starts causing problems.
Precisely. And there are already major clinical trials underway right now exploring exactly that. If you take people who are asymptomatic but test positive for amyloid on these biomarkers and you give them these amyloid-clearing drugs, can you actually prevent or significantly delay the onset of cognitive symptoms altogether?
Wow. That shifts the goalpost entirely, doesn't it? From just slowing decline to actual prevention.
It does. And that leads naturally to this idea of developing dedicated brain health services clinics focused on identifying and managing risk in people before they develop dementia. And remember, this isn't just about drugs. We also have strong evidence on primary prevention.
Right, the lifestyle factors.
Exactly. That big scientific review identified 14 modifiable risk factors, things we can actually do something about, like managing high blood pressure, stopping smoking, reducing air pollution exposure, tackling social isolation. Together, these factors might account for up to 45% of all dementia cases worldwide.
45% preventable through lifestyle and public health changes.
Potentially, yes. So we have these two powerful avenues opening up. Biological targets with these new drugs and diagnostics, and modifiable lifestyle or environmental targets.
It feels like, while the debate around the current drugs, their cost, their specific benefit is absolutely valid and necessary, the bigger picture is shifting undeniable. The science is moving forward. The clinical possibilities are expanding. Alzheimer's is starting to look less like an inevitable, untreatable fate.
I think that's the key takeaway. What we're witnessing, despite all the controversies and challenges, is arguably the beginning of Alzheimer's transformation from being seen as this universally fatal condition into something that just might become a preventable or at least manageable chronic disease, like heart disease or diabetes.
Which brings us to our final provocative thought for you, the listener, to really chew on. If these ongoing trials do eventually prove that clearing amyloid in people who are cognitively healthy but biomarker positive actually prevents the disease from starting, will that change the equation?
Will society then be willing to overcome this intense debate about cost and resources? Will we decide it's worth the massive investment needed for widespread population screening and early proactive intervention to potentially stop Alzheimer's before it begins?
When you weigh the potential cost of preventing a global catastrophe, estimated at $1.3 trillion annually, against the cost of treating it late with expensive drugs, where does that balance ultimately fall? That's the huge question looming on the horizon.
Thanks for tuning in to the Health Headliner podcast by To Digital. Like and subscribe for more health news and breakthroughs. Stay healthy and informed. See you next time.